Steve, Joyce brought up the issue of cost and benefit design, which is often a key issue in patient care, but particularly noteworthy in oncology where we're dealing with life and death disease. Insurers have to be struggling with this constantly. Do you like having an arbiter like an ICER that would have that kind of clarity to provide, because so that you get around the off-label and some of the other problems, and in doing so, the trade-off be that if there was that arbiter that said this is the appropriate therapy in this patient at this time, that there would be remove those prohibitive costs on the patient. What is the industry, and I know you only speak for yourself in your one plan, but where do you see the industry going?
Yeah, it's a really profound question, Bruce, and patient cost burden and what individuals will bear from a out-of-pocket or, again, patient cost burden perspective varies widely. We have some plan sponsors that have very, we'll call them generous plan designs where there's limited out-of-pocket cost. There are products that people purchase with sort of eyes wide open, but never thinking perhaps, Kelly, about getting cancer through the Affordable Care Act, the ACA, and there's kind of a fancy term called actuarial value for bronze, silver, gold, and platinum, Bruce, the so-called metallics. So the bronze would be less generous, and a person may well find herself or himself with high out-of-pocket cost, which she or he potentially could not afford. And then working with Bill or Joyce, looking at what those treatment alternatives might be within the construct of affordability. There is other complexity associated with the site of service. So it might be actually less expensive for the person to get an infusion therapy versus an oral, because of the way the plan is structured and designed for patient out-of-pocket expense. So a lot of complexity there. I wish I had the answers, and I guess it might be health czar if I did, but there's a lot to unpack in your question, and I'd say there's no easy answers. Joyce mentioned there are foundations out there which do good work to support people's patient cost burden, and then there are decisions. You mentioned ICER, there's National Institute of Clinical Excellence, which people look to sometimes across the pond. There's the ASCO value framework. NCCN more recently in their guidelines have included some economic considerations. Kelly mentioned the notion of financial toxicity as well. So again, a lot to unpack there.
Kelly, I'm curious, and it's like I never known a situation like this. How far to go, but how have you been able to afford your therapies?
So I've kind of run the gamut between having private insurance. I worked for corporate Walmart for 20 years, and up until about 3 years ago, I was still working there. So they pretty much covered everything. My insurance was phenomenal. I paid $50 a month for my premium, and it was pretty much seamless. Then I retired and went on to the COBRA situation where the premium was much higher, and then had much greater out-of-pocket expense, obviously. And then transitioning on to Medicare, where the donut hole is quite large. It's been a challenge. So when I was able to afford medicine or the Ibrance and Faslodex, which together are around, I guess, $24,000 a month. I have great relationships with pharmaceutical companies, and I was able to get a grant through Pfizer to cover the cost of the medicine. The copay is around $2,000 a month. So, and I wonder, was that because I had that relationship, or was it because that information is readily available to patients? So I worry sometimes that
yeah. Well, speaking for 6,000 patients didn't hurt.
Yeah. Well, and that's what I do. I share what I learned with, you know, with the forums and with people that need to know this. And I'm probably responsible for some of the pot stirring and people that are asking questions about, you know, can I do this? Can I do that? I want patients to be informed, and I want them to be able to ask the questions and to feel comfortable. You know, I know it's an uncomfortable conversation, especially when, you know, you have payers and you have, you know, oncologists at the table, but we have to ask these questions because we have to learn, and we have to be part of this conversation. Even if it means being a little bit of a thorn in the side, because we have PhDs too, and they're patient history doctorates, and that's something that most payers or oncologists or researchers don't understand, because, you know, we live with this beast every single day. So was able to get the assistance through Visor to cover it. Then when I transitioned to Medicare, I was no longer eligible for that support, so had to go find, and continue to have to go find philanthropic support to get that covered. And thank goodness my clinic has a phenomenal social working area that actually helps with this, because every 2 months the fund dries up and we go find something else to cover it. And we go find something else to cover it. So I'm just kind of conditioned to being ready to get that call or that letter saying, Kelly, the money's out. Let's go ahead and figure out what else we can do.